And thank you all again for joining today's Chief Information Officer Forum. The CIO Forum has been around for almost 30 years, was long chaired by Dr. John Halamka and Bill Fander, who was at the time the Chief Information Officer for the Blue Cross and the Blue Shield. Today, our CIO Forum is chaired by David Carusio, the Chief Technology Officer for 32 Point Healthcare, and Bill Young, the Chief Information Officer from Berkshire Health Systems. Bill or Dave, any comments from you, any welcome notes that you would like to add before we get started? And I can unmute you, Bill, if you would like.
Oh, good morning, Denny. Sorry, it took a little while to get connected. Welcome, Dr. Kvedar. Am I saying your name right? Kvedar. We thank you for your time this morning on this very important topic. You know, telemedicine has been such a part of what we've been doing over the past year, and we look forward to hearing your thoughts, and thank you for attending. Thank you for being here.
And Dave Carusio, any comments from you before we get started?
I just want to echo what Bill had just said. Thank you for taking the time out of your day to join us and share some insights. Appreciate it.
Thank you, Dave. Just a few notes regarding today's meeting before we get started. As you can see, this meeting is recorded, so everything that you say is available for all intents and purposes for public consumption. So mind your P's and Q's. Secondly, a little bit about MHTC, very little bit. We are a data governance, a data services, and a data exchange organization. We merged with the New England Healthcare Exchange Network earlier this year, providing the combined organizations the ability to act as a clinical as well as an administrative exchange, increasingly important in today's interoperability economy. We also are leading through our data governance collaborative efforts to facilitate the process of getting from where we are today to where we have to be over the coming 2.5 years. There's a tremendous amount of interoperability and information blocking changes that are coming forward, not to mention surprise billing, price transparency, and advanced digital prior authorization as far as we know. So there's a great deal of change coming forward in the coming months, and we feel that MHTC is well positioned to do that, to support our members through very tumultuous times. We encourage you to consider membership. There are a lot of advantages to membership above and beyond these presentations, which we host approximately 50 times per year, webinars and meetings of various types. Important to remember that because everybody's muted, please put your questions in the chat box. We will be monitoring the chat box, and at a midpoint, roughly the midpoint of the presentation, we will stop and take your questions at the questions you've asked and ask them of Dr. Kvedar. Also, it's important to note that we will have some time at the end of the presentation for people's questions to be answered. And we will also have a couple of polling questions that will pop up during the end of today's discussion. Now to the business at hand, and for me to tell you a little bit about Joe Kvedar, who is at the Harvard Medical School and Mass General Brigham, or formerly Partners Healthcare. Dr. Kvedar has focused on driving innovation, creating a market, and gaining acceptance for telehealth for nearly 3 decades. He is now applying his expertise, his insights, and influence to advance the adoption of telehealth and virtual care technologies at the national level. Dr. Kvedar is a professor of dermatology at Harvard Medical School and chair of the board of the American Telemedicine Association. He's also co-chair of the American Medical Association's Digital Medicine Payment Advisory Group, which works to ensure that these digital technologies, these telehealth modalities, earn a reimbursement and an appropriate reimbursement at that. Finally, Dr. Kvedar is a member of the AAMC, or the Association of American Medical Colleges Telehealth Committee, where he creates tools that will enable medical schools and residency programs to integrate, embed more telehealth into the curriculum and the training of future practitioners. Joe is the author of 2 books, The Internet of Healthy Things and The New Mobile Age, How Technology Will Extend the Health Span and Optimize the Lifespan. It's a tremendous set of accomplishments, Joe, and with that, I turn it over to you. Welcome, Joe Kvedar.
Thank you, and thanks so much, Denny, for inviting me. I feel like I've been a friend of Mass Health Data Consortium for a couple decades at least, and so I want to make sure, can people see my screen? Can you see my screen, Denny?
Yes, we can.
So it's a wonderful, indeed, time to be here. It's also a wonderful opportunity for me to talk about telehealth, digital health more broadly, and how telehealth and has become a springboard in the last 18 months for us to think about a completely different healthcare delivery model. Now, I know this audience is heavily enriched for people who have heard about this topic over and over again, sometimes for me over the years. I appreciate that, but as we all know, the last 18 months really changed everything, and that's not a overstatement when it comes to thinking about digital medicine, particularly as it affects the way we interact with our patients. And so that's really what I want to spend my time with you talking about. We'll talk just a little bit about not much about the past, because it's honestly quite quaint when I look back at some of the slides that I was showing in January of 2020, and just how different the world is now. But indeed, how the pandemic affected that, and then what we can expect in the next few years. As we go through the topics, as Denny mentioned, we'll spend about half on telehealth, and I'll take some questions. And then after that, we'll talk about some of the more emerging technologies in digital medicine that you can watch out for and what's going on in that realm. So I'm looking very much forward to it. I do want to start by giving a shout out to the American Telemedicine Association. I'm doing my second round with them. I was the head of the organization for the year term in 2005, I think. And just by chance was asked to participate again because of some juggling of the top board positions a couple of years ago. And I said, why not? I feel like they're old friends. And of course, I landed there in the time of this great upheaval in telehealth. It is the organization that I like to say finds the rising tides, floats all boats, matters or initiatives for the field. We have over 400 members, going close to 500 now, from all sectors: payers, providers, suppliers, et cetera. And if you care about this topic and about moving telehealth forward, and you'll see in a minute, I think there's some much reason to continue to accelerate adoption. It's worth your organization considering joining, and I'll leave it at that. So again, this is the landscape that we'll cover, and you can see as we go down this list, it goes from sort of mainstream to less mainstream, all the way down to AI, which I didn't get a chance to review this with Denny, but I'm sure you've had lots of conversations, maybe even presentations on this. I'll give you my spin on it at the end, and I think it is interesting. And when I think about AI, I'll just say that, having been in the telehealth space, as Denny mentioned, for almost 3 decades. It moved at a glacial pace, but artificial intelligence is moving quite rapidly for healthcare and integrating into our processes very fast. So I think if you aren't on top of it, it's well worth taking a primer or two to learn what it's all about. And again, I'll try to say some basics as well, and then following it closely because it's coming at you and will influence everything about care delivery. So anyway, we'll save that for later. But this is the landscape that we'll cover in the next however long it takes. So I want to start out by just speaking to some of the changes that occurred in the era of March to June of 2020, which we call early pandemic. And you can see this, I think, really nice. This comes from a Wall Street Journal article. I'm not sure. I know it's a different source. I'm not sure where she got the source from, but I just liked her visual. And you can see the little dot on the top that in 2019, a tiny amount, 0.8% of total. And then in early pandemic or March to June, 30%. And it pretty much stayed at 30% for a few months. But as you'll see from the next slide, things have started to trend down. So one of the things that I want to talk about is, does this mean that telehealth is a failure? Does it mean that it was a pandemic only solution? And what you see here on the slide, this, by the way, comes from fairhealth.org. They have something called the Fair Health Telehealth Tracker, and it tracks commercial claims. So these are claims by people like me who see patients and then send claims in for telehealth visits. Not, and this is going to be important as I finish the story, but not from the large national providers such as Teladoc, Amwell, MD Live, et cetera. So this is claims from doctors like you and me. And you'll see that as time goes on, the volume and the percent of claims tends to go down. So the last month that I grabbed here, which is the last month they have data for, it's down to 4.9%. So if you look at the trend over these 3 charts, you'll say maybe telehealth was just something that we had to use when we couldn't do anything else, and maybe it's fading away. But I think the next slide actually speaks to that in an interesting way. And this is important, I think, for those of you who are in the provider sector to think hard about this. And I'll have more comments to make about the challenges that we as providers face, because that's what I know best. That's my world. But, you know, and as this slide indicates, and this is the source for this is an individual who works at one of the largest national payers. This individual asked not to be quoted by name and to have the company quoted by name. So it's an anonymous personal communication, but I trust this individual. I've known this person for years. And you can see what this person said, that in 2020, in 2020, 96% of their claims, this is one payer, but a very large one, came from what they call local providers. Again, that's people like me billing for telehealth claims. In 2019, 54% of those were from the big boys, if I can use that phrase, the Amwells, the Teladocs. And it's headed back in that direction. And to me, that really resonates because I really feel like there is a market there. And I'll share some reasons why here in the next couple of slides. So again, what I'm suggesting is that the Fair Health data that I showed you suggests that we as mainstream providers are backing away from this mode of healthcare delivery as we bring people back into the office. There's a lot of reasons that might make sense, and I'll share some of those as we go through the deck. But that doesn't mean that telehealth hasn't found its place in healthcare delivery. In fact, it has, And the slack is being picked up by these national companies like Teladoc, Amwell, et cetera, because telehealth really is now a household word. Patients have had these experiences, and happily, I say, because when you scale something as quickly as we did, it could be scary to see, especially in healthcare delivery. We don't tend to do things that rapidly, but it worked out well. Patients were largely happy. Doctors, I think I give them a lot of credit for trying new things. I'll share some more of those insights when I get to the slides on what's good for telehealth and what maybe is better in the office. But doctors really came to the fore and started really caring for people this way. And indeed, there's a continued volume of telehealth being delivered that was higher, even still at that 4 or 5%, much higher than pre-pandemic. And we've successfully brought the doctor's office into the home. Now, again, as I said in the very beginning, this gives those of us in the business a platform which we can build off of to encourage other innovations, some of which I will share with you as we go more through this talk. So it's a floor, it's not a ceiling. I implore you, if you think that the telehealth war has been won, to please re-examine that because of two things. One is that backslide in claims that I shared with you, which again tells me that as mainstream providers we're retreating. That might not be the best thing for us, but also the idea that video alone really isn't that innovative. It's just taking what we do in the office and bringing it into the home. And while that's great for convenience, patients love it. As all of you know, there's so much more we can and should be doing to digitize our healthcare delivery experience. So why is it, do we think that this market exists now? Well, no, I'm sorry, I'm going backwards. I apologize. Here we go. So I don't want to read through all of these. This comes from a COVID-19 telehealth consortium that ATA was a member of, run mainly by Mayo Clinic and the MITRE Corporation. But you can see, just glance at the numbers, 78%, 83%. These are all numbers, patients' enthusiasm for their telehealth experience. And again, I'll just say again, we did this almost overnight. So anytime you scale something that quickly, you expect bumps in the road. There weren't that many. Patients that experienced it really loved it. And in fact, one of the other ones I like very much to show is this data from MedPAC. I'm guessing many of you know of MedPAC. MedPAC is a group of advisors that advises Medicare on adoption of new codes and new modalities, and for many, many years has been pretty down on telehealth. And yet, in their most recent report, they came up with these two stats, which I just proudly show you. 90% of Medicare recipients were satisfied and 67% extremely satisfied. So there's this tremendous momentum around patient pull to do this. And it's because of the other half of this slide. What you see on the left is what I call the magic triad. When you get, and I think everyone can sense this, quality, access, and convenience, patients have such a positive reaction, and doctors feel for the most part, they feel fulfilled that they're able to provide these services in such a convenient way to their patients. So I do think it's here to stay. What's the mix of who's going to provide the services? That's a wild card. And again, as providers, I think we need to look hard at this, what I call magnetic pull back into the office. Is that the right thing for us? And are we setting ourselves up to have a whole sector of business that's out there that people want taken away from us by large national providers. Now, I want to make sure that you don't see me as in any way putting down the teledocs and the Amwells. That's not my point. They do a fine job, but the care is fragmented. And I think we need to really wrestle with that. And I think we as providers, it's a different conversation because we worry a lot about our primary care base, and this is a big part of it. So without being too preachy, I'll just leave it at that for now. And we'll probably come back to that maybe in the Q&A. So what is telehealth good for? The start is what I always ask my provider colleagues when we have this discussion is I ask them to think very thoughtfully and carefully and openly about this top question. What information do you need to make a diagnosis or create a care plan? And if you don't need to touch the patient, telehealth is probably a good solution. Now, you'll see here that there are three broad categories of things that are quite clearly good for telehealth. Mental health is the winner, without a doubt. I have some data in a minute that I'll show you as well, but mental health is now 80 or 90% delivered this way. Most of you probably remember that in January when Governor Baker signed into law a telehealth bill that in perpetuity, or at least until someone changes the law, behavioral health visits will be covered by payers at parity to what they would be paid for in the office. So that's a very big step, and it's appropriate because what you need to make a diagnosis or care plan is a conversation with a patient. And once again, video is a perfectly capable way of doing that. And some would say, some students of mental health and telehealth would say it's even better because the patients are, I'll use the term in situ, they're in their home. They're surrounded by their surroundings, which can give the doctor clues, but also the patients can be more themselves. So it seems to be a win for everybody. And it's by far and away the biggest winner of this whole 18-month journey. The next big category is virtual urgent care. And you can see some of the indications here. These are things, and we did this mostly through health plans prior to the pandemic. Again, most of the time, health plans would contract with the national providers because it gave them 50 state coverage and because it gave them control of the process. And that's going to be a theme as we talk about the payer angle on this. But these, if you are a member of a health plan, virtually all of them prior to the pandemic, you could go to a website, you could sign up for a service, and for one of these minor complaints, have a telehealth visit. It wasn't always heavily publicized. And according to my friends in the payer industry, it wasn't usually heavily used, but it was there and they offered it. And they felt like it was more of a stay in business app for almost marketing, really, for patients than something that they felt was going to be heavily used. Of course, now that's changed and payers are really grappling with how to deal with this fact that it's now a household word and everyone knows what it is and patients kind of like it. We'll come back to that. And then finally, the third category, chronic conditions, hypertension, diabetes, heart failure. I'll talk more about some of these when we get to the section on remote patient monitoring in a few minutes. But the patients that you as a doctor know well, and you're focused on something fairly narrow. Again, as a dermatologist, I do 80 or 90% now of my acne follow-ups by telehealth. It's just simple because patients can send me images. They don't need to come in for that. And they love the convenience of having their meds adjusted without having to come in the office. So that's an example. I've got diabetes, hypertension. I mentioned here, again, as long as you have a blood pressure cuff, or in the case of diabetes, blood glucose monitor, you can easily move that data around and care for those patients without them leaving their home. Now, what's interesting about this next slide, and this slide I created, well, a year ago at least, and have been showing it, and my viewpoint on it over the last year has been changing because inevitably I'll get doctors who will challenge me on some of these contraindications. The only one that really sticks is the last one. We're not yet doing appendectomies in your living room, and I don't think we will for many, many years. Of course, there's hospital at home, which I won't cover in any detail. I'll just mention it. But that's things like inserting IVs and things like that. It's not doing operations. So really anything procedural still requires a trip to a facility, as well as probably virtually all imaging, except some ultrasound now is portable. But once again, these things are, for the most part, bind you rather to a facility. But everything else on here, I've had people challenge me on. And I love that because, for instance, I'll tell you one quick anecdote. One friend of mine who's an internist, when I said complete annual checkup, she really took me to task. She said, I do all these virtually now, and I'm quite happy to be able to do it. The patients get their labs done, of course, separately. They have to travel for that, but I'm going to come back to that because home lab testing is really on the brink of bursting out. But for now, they have to get their labs done elsewhere. But she, for instance, instead of listening to their lungs, has them walk a flight of stairs to see if they get short of breath. And so she's figured out all these ways patients can palpate their own abdomen, et cetera, et cetera, et cetera. So, my hat's off to people who want to be that creative, as long as they feel like they can deliver high quality care. And that's something that I think is it's a fundamental that we need to deal with as doctors. And it's something that I think we're sort of a little bit slipshod on right now. And I'll come back to that. I think that's very important. So anyway, you can see on here things like diagnosis, for instance, of new cancer diagnosis. When we started the pandemic, I said, oh, that probably should be in person. Probably not. Probably can be done via telephone or video if you have a caring individual and the right context. So very long-winded way of saying there isn't that much that we can't do by telehealth these days. And that's pretty exciting. Now, with that said, I have one more slide on the mix. And this is from the Commonwealth Fund, was published in, I think, April or May of 2020. But I like the chart, and I apologize if it's hard to read. I probably should redo this chart if it's hard to read the lettering. But I'll tell you what it says. During that lockdown phase, again, March to June, this is a reflection of which specialist suffered the most from decline in volume. And you can see the top is ophthalmology. And that's the reason I've chosen this chart. And indeed, my wife's an ophthalmologist, so I know this quite well. There's very little they can do by telehealth. It simply is a machine-driven, device-driven diagnostic process. So you pretty much have to go in for that. Again, at the bottom of the chart, behavioral health. Once again, I mentioned them before, so I don't want to be redundant on that. And up in between are many others. I've circled dermatology. A, that's my field. B, I used this slide when I was talking to some dermatologists to educate them that even though people say, oh, dermatology is a natural for telehealth, we do a lot of complete skin exams. We do a lot of little procedures. So I would say between really 5 and 10% of our volume probably is appropriate for telehealth. And the rest, unfortunately, in a way, needs to come in. But that's just what we've learned as we've really taken this stuff to scale over the last 18 months. So where does that leave us in terms of trends to watch and what to think about next? So again, I'll spend a little bit of time on this slide. It's packed, so we'll walk through it. The top set of bullets is about some of the regulatory matters we need to all pay attention to. And we're really at this point now, it's interesting, in the middle of 2021, where state by state, the public health emergency is going away, as you know. And in many cases, not all, but in many cases, one of the things that governors are tending to not sunset are the telehealth matters related to care. So we tend to see this, and ATA is a wonderful policy initiative and a wonderful policy director, a fellow named Kyle Zebley. And he follows really literally all 50 states. There's about 20 or 25 that we're heavily involved in. And for the most part, and that's true in Massachusetts, that we're not yet at pre-pandemic reimbursement rules for telehealth. The government has a really big challenge, the federal government, and I'll be quick about this because I know this is largely a local audience, but just quickly, there's a statute called 1834M, that's the lingo. It was passed in the mid-1990s, and according to that law, Medicare can only reimburse for telehealth if the patient is in what's called the health profession shortage area, which is a very narrow rural designation. The doctor has to be in a facility and the patient has to go to a facility. So it's a very mid-90s view of the world and quite restrictive. That went away with the PHE, but when the PHE is lifted at the national level, if that law is not changed, then we will have a pretty significant ice age over the telehealth reimbursement landscape, because Medicare won't reimburse, and of course private health plans generally will quickly follow suit, because again, they probably want to go back to the strategy they had before where they control it. They'll offer it, but they won't let people like me bill for it, because that gives them less control. So we have to watch that carefully. ATA is spending as much policy energy as we have trying to get that law overturned. We'll see what happens. Various pundits have said that they expect that the federal government will extend it for 2 or 3 years to study it further. Again, we'll see what happens. The public health emergency at the federal level is probably going to last through the calendar year, is what we've been told. So stay tuned on that. The technology bullet is really about HIPAA, and I'll be very brief on this because it's, I think, largely been solved. In the beginning of the public health emergency, we as providers were allowed to use anything, FaceTime, Zoom, Google Chat, etc., Skype, to do video visits. And what happened was that almost all of the companies that cared about video quickly developed a HIPAA protected or HIPAA compliant solution. And so most providers now are back in the mode of a HIPAA compliant video platform. And I'm sure many of you know this, but if providers don't feel like they have the resources to, say, integrate a Zoom into their electronic record the way we did at Mass General Brigham, then there's Doximity Dialer. Doximity is a social network, perhaps many of you have heard of it, for healthcare providers, and it's free. Doximity Dialer is a video connection that's HIPAA compliant, that is free. So you can't beat free, and it's pretty darn good. So I think this issue of technology is largely gone by the wayside. And even though you can still use a non-HIPAA compliant software, I highly recommend that you use something that's secure, because of the other thing that's come up over and over again in the last 18 months, which is privacy and security. Now, the last one on the list is licensure, and I am fairly sad to say that I don't expect a lot of movement on that. I'll give you, again, the local view on this. Is it more or less Massachusetts and New Hampshire and Rhode Island have now closed their borders to cross-state telehealth in the last few months. Sadly, I feel bad about that, but that's the state licensing boards, and they have their own reasons for doing what they do. There is a regional compact / national licensure compact Hopefully those will take a hold, and we'll see in the coming years more cross-state opportunity. But it is a really tricky issue, and providers are quite unenthusiastic about letting folks from other states come into their markets. So I don't have a lot of hope on that one. The second set of bullets here is about new technologies, and I alluded to this when I talked about lab tests a minute ago, but there are three here. I'll go over them fairly quickly. We're going to take a break in a minute and take some questions. But digital biomarkers is one of my favorites. These are software tools that live on your mobile device that measure something about you. I'm, full disclosure, advisor to an Australian company in this space that their software, based on the sound of your cough, can diagnose respiratory illness. So if you picture yourself on that video call with your doctor and you cough, the doctor will be able to, without listening to your lungs, make a diagnosis of your respiratory illness. That's pretty interesting. It's CE approved now in Europe, widely used in Australia, and going through the FDA in the States. And they're not the only company doing this. Also, you can do it for behavioral health, i.e. depression screening, et cetera. So really interesting space, digital biomarkers. Home devices, and I'm going to say a little bit more about this when I get to remote patient monitoring, but as you probably all know, there are devices now that are almost like the tricorder. They can look in your throat, look in your ear, check your heart rate, check your EKG. You can check your EKG on your Apple Watch, et cetera. So this is a rapidly evolving area. And then home lab testing is really about to break out. In fact, I forget which telehealth company, Roe it is. Roe is the company that had made themselves famous with the offering erectile dysfunction meds, but they just acquired a home testing company, and that's, I'm sure, not the last of those acquisitions. So lots going on. Asynchronous care, remote monitoring. We'll cover both of those a little bit more in the next few minutes. Now, the business implications for providers. Well, I've talked about almost all these, so I'll be succinct here. But there's this temptation to draw back into brick and mortar. I mean, we lost a lot of money a year ago. We were hemorrhaging from not doing things like total hips, total knees, neurosurgeries, transplants, et cetera. We have beds, we have office space, we have buildings. For our economics to work, we need to use those buildings. As I said, this really is, I think, a time for us to be very reflective about that, because if we push our providers to go back into those buildings, we might be leaving an enormous market on the table for others to move into. And you could say that's already happening. So I worry about that. And I think there's a future where the provider becomes the brick and mortar crowd, and you can do your healthcare in multiple different ways digitally. But if you need that rare time you need to go to an ICU, an emergency room, or an operating room, or maybe get an X-ray, you come to a provider. That doesn't sound like a great future to me. And so all these other things fall in under that workforce implications, overhead calculations. It's all about how we grapple with this fact that we have big buildings as we move into an era where digital will come first, and time and place independence. I've talked about the payer side, and I confess I know less about that because I'm not in that industry. I've never worked in that industry. I have lots of friends in that industry who share with me some of these things, but they're worried that we'll add with telehealth, that we won't substitute, that the increased access provided must be kept in check. So how do they continue to offer these services in a new era where they can't control it as much as they once did? It's an open question, a very, very difficult one for them. Now, there are some wild cards, and again, this is the last slide before the midpoint Q&A. So there's some wild cards that will really help us frame how things go in the next few years. And more or less, these have come up already. So the lack of clarity on reimbursement that I spoke about earlier is one of the reasons that providers are retreating back into brick and mortar and not making big strategic investments in telehealth, because they just are worried that they'll deploy precious capital and then have to retreat anyway. That's a challenge, and I fully understand. None of these things are illogical. It's a challenge. Now, I haven't talked about value-based reimbursement much, but it's out there and people say it's coming. And part of the reason I don't bring it up in the early part of these kinds of talks is because we've been talking about it for at least a dozen years and not much has happened. So I've become a little bit jaded, I confess. With that said, people say it's really going to be the next thing. And I mention it here because if it is widely adopted and if we do get pushed in that direction, telehealth is a natural for value-based considerations because it enables us to be more pervasive and more, in a lot of ways, more efficient. And the last one I think is really interesting. So this is about the conversations that I have with my provider friends around the country. I'll often say, what's the big worry that you have? Usually this is in the context of my role as a chairman of the board of ATA. And I often get back, well, I'm worried that consumer tech companies, because Best Buy, Amazon, they're all in the space now with serious programs, that they're going to come in and take away primary care from. And again, if that's true, and the way to combat that has to be by investments in telehealth, that might push it forward. But if we wait too long and the market gets taken away by the Teladocs, the Amazons, the Best Buys, we'll be playing catch up. And I don't know, maybe that's a good thing for patients because choice is good. But I worry for my own provider brethren in that context. All right, so I'm going to take a minute now and see if there are questions. And maybe, Denny, you can share them with me if there are.
Sure, Joe. I think we have questions asked. I know Janice Karen is on the line, and I'm going to unmute Janice, who is collecting our questions and answers. Let's see. Janice, are you there?
I am, Denny.
And do you have questions that have come across the transit?
There are some questions that have come across the transit. 1 second. So there were so I'm not sure, this is more of a comment, but maybe you could comment on this. Or it's asking for your comment. 2 concerns about how telehealth got added during the pandemic. First, this was added without thinking extensively about workflow integration with EMRs. In other words, gathering appropriate pre-visit information or billing management or things like that. And also HIPAA requirements were temporarily removed. So now that we're getting back to normal, what is your opinion about what we need to fix to fully integrate telehealth into non-urgent ambulatory care?
That's a great question. In 2 or 3, it allows me to emphasize 2 or 3 things that I said, because I think that the reason that you don't see a lot of that going on reflects on the last comments that I made, that it requires resources. And it's the kind of investment that a provider would make if they were confident that there was a future where they could make economic sense of it. And right now they aren't. It's interesting, your commentary about pre-visit and so forth. And I mean, I can only speak to my organization's efforts on this behalf. And of course, nobody's perfect. But I do tip my hat to the telehealth team at Mass General Brigham, which I'm now only an advisor there. I'm not day-to-day involved anymore in an executive capacity, so I take no credit for this. But they did do quite a fine job. Our patients do fill out a lot of forms online before visits. And Zoom is directly integrated. You can launch a video call from Epic. Patients can request a video call and launch a video call from MyChart. So those are all good things. We've made those investments. I think, and again, I applaud the group for that leadership. But there's no question that you're right, that we have a long ways to go to make the experience completely integrated and completely seamless. As I said, I'll just say one more time that I think most people realize that needs to be done, but they're scared to make those investments until we have a clearer path to long-term reimbursement.
Thank you. Janice, other questions?
Comment here from Ray, who just mentions that he was involved in a pilot program that conducted telemedicine between Logan Airport and MGH for dermatology consults in 1971. That date is not a typo.
Yeah.
And I'm not sure what exactly he was saying was interesting, because I'm not sure what you were saying at the point that came in. But so just a comment from Ray. Ray, if you want to follow up on that, feel free. If there was something particular you wanted to point out, or was commenting on would be interesting. And I don't know, Dr. Kvedar, if you have a comment on that program.
Oh, well,
telehealth has been around so long.
Sure. No, I'm incredibly excited to have someone in the audience who was there. That was a pivotal moment in history. A guy called Ken Bird. I'll just a very quick anecdote, because it's a fun one. It's about mother being necessity being the mother of invention. But we used to run a clinic at the Logan Airport for immunizations and things for people who were coming in from foreign countries and the like. And it was Ken's clinic, and he got so frustrated with traffic in the tunnel that he decided he was going to set up a microwave link and do it by microwave video. And there are all these wonderful archival pictures of Ken and examining patients and nurses in the outfits of the day with their nursing caps and so forth. And indeed, my chair, the chair of the department when I trained, Tom Fitzpatrick, was a participant in that and did a lot of dermatology exams. So yes, really wonderful to hear that. It was, some people credit Ken Bird with the term telemedicine, so it was a non-trivial exercise and really way, way, way ahead of its time. Thank you.
And thank you. I wasn't allowed to unmute myself for a second. Just as a point of reference, the gentleman in the chat was working with Dr. Al Kopf of NYU and the Academy of Dermatology. So
Great.
That part of the program. So some more questions. Is the EMR the platform of choice, or is there some other mechanism that might be better suited?
Well, I think most doctors don't, or healthcare providers don't like to have more than one screen open at once. And the EMR is the heart of where we take care of our patients, where all of their information is. It's the information system of patient care. So yeah, I think having this activity integrated into the EMR makes a lot of sense. Another just quick anecdote, I didn't share anything about e-consults. That's another very big initiative at Mass General Brigham, where a primary care doctor can request what we would have called an electronic curbside, right? A quick opinion from a specialist. And in dermatology, that means sending me a couple of pictures and a sentence or two of history. We do that all through the chart. And in 4 or 5 years, we've avoided something like 70,000 office visits to specialists, because we'll get those questions answered with the primary care doctor. So that's one example of why it's so powerful to do it within the context of the EMR.
Great. This next one is a question that's close to my heart. How do you know that Massachusetts is a two-state consent state for recording, a two-party consent state? How does someone using telehealth know that the session is not being recorded and used for visit notes if they haven't permission to do that?
Oh, I don't. So the direct answer to the question, it's a good one. I don't know the answer to that. I mean, as we use Zoom in our case right now, I can tell this is being recorded. Zoom will tell me that. So that carries through in our case. But there may be other platforms where that isn't transparent. I think from a provider perspective, no one's really eager to record these things that I've ever talked to. So I don't think that's an issue. Maybe patients would be recording for their own intent. I can't comment on that, but it doesn't seem to be a big issue. And as you point out, both parties would need to give consent for it to be legal. So I don't think it's a big matter of concern.
Yeah. Can I just do a quick follow-up on that? Do you feel the
Please.
same way about transcripts? Because I know some telehealth platforms can automatically generate transcripts, and they don't necessarily have exactly the same legal.
Yeah. Well,
protections.
again, if this gets into how people do notes and how they capture things, and I think you could argue both sides on that. How accurate is my recollection of the history you gave me? I mean, as we know, we all filter tremendously as we listen and record our observations. So having a transcript is exactly what was said. I think just on the other hand, just dumping that into a note isn't particularly useful. So using it as a tool to extract bits of history for a note probably makes some sense, or bits of care plan that you want to put into a note. But
Yeah.
it,
I'm sorry, I didn't mean to interrupt you. My apologies. Go
That's
ahead
it.
and finish.
I'm done.
As a note of personal comment, if that's okay, I've got to say that I feel like if you don't do it in person, you should be able to do it for a telehealth visit from the standpoint of recording transcripts. If you have someone sitting in there and you tell me we're gonna transcribe this entire visit and I agree to that, then you should be doing that on site or telehealth or whatever, and that's fine.
Yeah.
But-
Well, and again, we don't want to take the debate too far, but remember now we have virtual scribes, and I'll sit down with my primary care doctor and he says to me, I'm going to turn on this recorder and my virtual scribe is going to transcribe the event. Is that okay with you? And so that's close. It's not exactly what you said, but it's close. And that's done in the office. So these things are merging, I think.
Okay, well that's interesting. I haven't encountered that yet. But in any case, moving on to the next question. This is a good one. What controls do insurers have for in-person visits that they don't have for telehealth visits?
Well, so I think it's let me see if I can sort that out. It's more about, so let me give you an example of, again, from my world as a dermatologist. And this does happen. So someone shows up on I do my telehealth visits on Tuesday afternoon. Someone shows up on my schedule with a new bump on the forearm and sends me the pictures, and we have our video call, and I say, yeah, that looks like it might be a skin cancer. Let's get you in for a biopsy. They come in for a biopsy. Now, if I'm not thoughtful, I might bill the insurance company twice for the evaluation and management part of that, which would be wrong. If I bill the evaluation and management for the telehealth and then bill the biopsy when they come in, that's perfectly fine. But it's those kinds of overlaps that they worry about, that you see someone by telehealth and you say, oh, I don't know, I need to see you in the office. And then you just repeat everything you did and charge twice. I don't know if that answers the question, but it's less about the control that they have with you in the office and more about their worry that you're duplicating services and billing twice.
Okay, great. Let's do we have a bunch more, but I know that you have more of your presentation. So maybe two more questions now.
Sure. Yep.
The next one is making patients go back to the hospital for telehealth appropriate visits risks alienating patients who found telehealth much more accessible than in person. And I'm going to also amend this question slightly, add a second portion. But some providers are already starting to make those mandates. Can you provide some thoughts on where that balance should be and what's the right way to do this?
Well, I can see both sides of it. So especially, by the way, and again, right now, you can say we're going to get paid. I'm not sure how much longer we're going to get paid at office visit parity for telehealth. And I don't mean to make it all about economics, but let's face it, economics play a role. It just is a fact of life. So I don't like it to hear that, and I know that's happening, and I'm not fond of it as a advocate. But I also feel like, and I gave a talk recently, and I said, those of us who are advocates have got to stop saying it's the right thing to do and patients love it. We need to find compelling reasons for providers to adopt. And one of them is going to be if the economics work. And that includes not just the reimbursement, but it includes how do we use the brick and mortar. And if we have lots of brick and mortar fallow because we made investments in buildings, again, it's a challenge. Now, I've made it clear that I think there's a risk to us as providers if we ignore that and simply retreat, because I think we might fill the buildings for a couple of years and then we might see them empty out because people are getting their digital care elsewhere, not because we insisted that they come back in. So I think it's a short-sighted, understandable. As I said, we lost a ton of money a year ago. It's not been easy. So you can see both sides of it. There's no kind of right or wrong there. It's how you believe the future is going to shake out, and that's why I mentioned those wild cards before we took the break.
All right, great. And then one more for now. And those of you who asked questions haven't asked yet, don't worry, we'll have another question and answer session at the end. So hopefully we'll get to other things. Are you aware of any reports or studies that compare patient outcomes for telehealth versus live visits for chronic conditions, low acuity, stuff like upper respiratory infections, rashes, dysuria? I apologize if I said that one wrong. I'm not a medical doctor, but other sort of chronic low acuity conditions.
There are. One of the things that's interesting about telehealth as a research endeavor is that the word itself, I mean, if you're studying a new medication for high blood pressure, let's say, you've got the diagnosis, high blood pressure, and you've got the medication, and they're both pretty concrete. Telehealth can mean a video visit, it can mean an asynchronous visit, it can mean someone who had a device at home and monitored themselves. So the literature is vast, and there have been studies looking at outcomes, but I would say there's no great uniformity of methodology, and there's no great uniformity of conclusion yet. And it's largely because the intervention itself is not well defined in most cases.
Great. And I know I said that was last, but there's actually another question that is like the second half of that question.
Okay.
So I'll just do that really fast.
Yeah.
And this person is particularly concerned about mental health and behavioral health issues, but she's wondering about Zoom fatigue in particular, if that's a factor for either patients or providers, as well as the outcomes question.
Sure. I haven't heard that. Again, I've talked to a lot of mental health practitioners who are extraordinarily enthusiastic about doing their practice via Zoom. So I haven't heard them complain of Zoom fatigue. I think, keep in mind that behavioral health always has a large demand in excess of supply, and people in the industry care about that. And so this is a tool that enables them to extend access, and John, by and large, they feel good about that. So I haven't heard of that problem.
All right, great. Why don't you go on? We have a couple more, but I'll hold them for the Q&A session at the end. Thank you.
All right. So the remainder, and it won't, we only got another half hour, but this won't take probably 10, 15 minutes, because I'm going to sort of like a skipping stone on the water, talk about some things that you need to pay attention to and just keep in your mind. But these are all things that are either coming into focus or future. And remote patient monitoring is coming into focus. Why? Well, again, now that people have had this experience with telehealth, they can say, oh, by the way, if you had your blood pressure readings, we could make this visit much more useful for both of us. So the idea, and by the way, speaking, Denny mentioned that I'm co-chair of the AMA's reimbursement committee. There's a lot of new codes to allow healthcare providers to bill for things like remote patient monitoring and telehealth. So that's also out there. And as I've said multiple times, that does make a difference. So the value in remote patient monitors illustrated on this slide. This is Connected Cardiac Care, which is a CHF, congestive heart failure monitoring program that we launched at Mass General Brigham, quite a few years ago. It's still in force. Patients get the sort of equipment that's shown here in the cartoon, and they have to measure vital signs once a day. And a nurse in a nurse call center will call them if the vital signs are out of parameter. And what we've shown here is decrease in admissions, all cause, it's the top line, and heart failure related is the bottom line. For a year following the intervention being a 2-month intervention. And you can see it's quite compelling. There's a lot of things going on here, and if we had more time, maybe we could dissect it. But in essence, the patients use these parameters as tools to help them change their lifestyle, eat less salt, drink less fluid, and so forth. And then, of course, there's the nursing intervention, which is much quicker if the software flags a patient as being in need than waiting for that patient to call when they're already short of breath. So it's a very powerful model. The big value is in efficiency. And I mentioned earlier, this is the kind of thing that's really powerful in the context of value-based reimbursement. So take that for what it is, but it's up and coming. And again, there are now codes to reimburse for this kind of activity, as well as hypertension monitoring for patients that are newly diagnosed, glucose monitoring for patients who have type 2 diabetes, and several others. Now, digital therapeutics, really fascinating, and I'll just, again, I don't know how familiar you are with this, but it's another one that's really about to hit the market in a big way. But this is a group of organizations, companies, who have made the case that software tools can, and sometimes in collaboration with a device, but most often it's an app on your mobile device, when engaged with that patient, can result in a therapeutic outcome that is as good as or better than a pill or an injection or an infusion. In other words, a therapeutic. And there are several examples here. There are many others. All of these companies have shown this paradigm to make sense. The story I probably like the best is Akili Interactive. This is a company that has developed a game for kids with attention deficit hyperactivity disorder. As I'm sure all of you who've had experience with this, and it's such a common condition that most people either have had a direct experience or have a loved one. The medicines that we prescribe for this are pretty bad with side effects, and this game is much more powerful. So that's an example of a powerful digital therapeutic. And these other companies have done this as well. Paratherapeutics of note is about to, if they haven't already, do an initial public offering through a special purpose acquisition company, but they've probably been the leader in pushing this vision. And two of their products are shown here, Reset and Reset O. Reset for substance use disorder, Reset O for opiate use disorder. And as you can see from the bottom right, the committee that I co-chair is looking hard into how to reimburse for these services. Just quickly, the dilemma, I think, for this group of companies is that they took the moniker therapeutic. And as those of you in the industry know, if I write a prescription, I don't get paid anymore for writing a prescription. It's part of my evaluation and management service. That therapeutic goes through the pharmacy benefit supply chain. And there's not much margin in there, and these companies would rather go through the disease management supply chain. So they're grappling with how best to get their software paid for. And that's really the theme for the next one that I want to mention, which is the last of the forward-thinking ones, and that's artificial intelligence. Now, depending on where you sit in the industry, this can be frightening or it can be exciting, and sometimes both. But I like to tell this story to sort of illustrate why I think it's a bigger deal than whether it's going to replace jobs or not. I think that's a fairly narrow-minded view of this topic. What these data illustrate are from a study where the artificial intelligence algorithm was trained to find metastatic breast cancer tissue, or cells rather, in lymph node tissue. And you can see that the computer alone was about 92% effective at doing this. But that if you gave the slides to a pathologist, they were 96% effective. So the computer did not beat the pathologist. However, this is the important part of the story. When they went back and had the computer cull out the difficult cases and share those with the human being, in other words, do a triage function, together they were 99% effective. And I think that's one example of how we want to look at this, is that computers can do a lot of things that we don't do well, but they don't do judgment. They don't do caring. They don't do emotional intelligence. So doctors who are worried about their jobs being taken away, I think a little bit short-sighted. One of my other favorite people in this is a woman named Janelle Shane, and her website or blog is called AI Weirdness, if you want to be entertained. And she points out that the average AI today has the intelligence of a snail. So let's not worry so much about the computer taking jobs away, but marveling at when you have a very large data set and you want to find patterns, computers do a really good job of that. And they use those patterns to predict the next data point and how it's going to fit. That's what AI is, and that's really where AI succeeds. So we need to offer our judgment on top of it, but it does an amazing job. This is one example of AI that really is very far ahead of the rest, I think, and that's in ophthalmology. The device, and it's on the market now, primary care doctors can use this device, and it's like one of the ones you put your chin into at the ophthalmologist, but it goes in the primary care office. It takes pictures of your retina, as illustrated here, and will help that primary care doctor by using an algorithm to detect whether you have diabetic retinopathy, if you have it, whether it's worse, and that helps them triage referrals to ophthalmology. Now, I think that's interesting, but what's even more interesting is that there's now a reimbursement code for that, and it's listed here, and that sets up a paradigm where that AI invention, or intervention rather, can be thought of in the same way as a strep test that you might perform in your office, or another lab test that you might perform. There's a code for you to reimburse for getting that piece of information that guides your decision making. Pretty interesting, and I think we'll see more of that as time goes on. So I'm going to wind down now. I'm just going to say that I hope you understand how this is really all moving in an incredibly exciting way. The solutions are here for the most part. I forget now the man's name, I can't remember, but the famous quote is, "The future's here, it's not evenly distributed." And that's really the case for digital medicine. And in the next few years, you're going to see this stuff come together in a way that is integrated, that doesn't look like separate types of apps, but really sort of puts together a digital experience for our patients. And I think we need to really work hard to be a part of it and not let others take it away from us. That's us, I say, as a provider side. So I'll leave you with some unanswered questions. Telehealth's here to stay. I hope I've convinced you of that, but I don't know who will be providing those services. Will hospitals rather be handcuffed by their fixed assets, by their buildings, by needing to fill beds? When will the public health emergency sunset? And what's the future of value-based care? Every single one of these will help frame how big telehealth gets in the next few years. And then you as a patient, this is really for you as a patient, advocate. If you have had a telehealth experience and you felt it was a good experience, tell your human resources professional, tell your health plan, tell your elected officials, don't let us slide back to pre-pandemic healthcare. That was one channel and not particularly patient friendly. These are my contact information. I'll leave that up and we'll go back and take whatever other questions we can in the next few minutes.
Joe, thank you for that. That was a terrific presentation. I know we have more questions coming up, and we have approximately just over 15 minutes. Let's call it 15 minutes to get through those. Janice, do you want to follow up with
Yep.
the remaining questions?
Absolutely. So a couple still left over from the first section, and then we'll move on to the new one. And actually, this is sort of also related to the last thing we talked about in the last session, but telehealth engagement for mental health treatment was high. Now we see, this is sort of the reverse of that previous question. Now we see many people want in-person treatment instead. Could this be the result of extended isolation when people are just longing for more human touch? Where do you think the balance is going to end up in 6 to 12 months? And obviously a lot of those other factors that we talked about in terms of some providers no longer doing telehealth, or some providers eventually deciding not to, possibly because of some of the exemptions in terms of payments and other things going away. But have at it.
Well, my crystal ball is pretty cloudy, but sure, I think absolutely that there is there's an argument to be made that people felt cooped up and they want to be out, and so people have varying types of relationships with their therapist, right? And if their relationship with their therapist is the kind of one that they long for, an in-person connection, that's probably no different than longing to meet friends at a restaurant or you know, the kinds of things that we're all overdoing now because for a year and a half we were stuck without doing them. So I see that. On the other hand, as I said earlier, there's so many people who have the need for therapy and they live busy lives and they can't necessarily take out a big chunk of time, and online is a perfect way for them to do it. So I can see both sides of that. Where will it come out? Well, I think by and large, the industry, the behavioral medicine industry is moving virtual. It's not just video visits, it's online CBT, it's all these other things that enable people to get therapy that need it. Because again, we're in an age where everyone appreciates the need for therapy. When I was a kid, it was quite different. The need was probably there, but nobody wanted to admit that they needed it. So it's blooming and blossoming and burgeoning, and to fill that gap, we're going to have to do a lot of it virtually.
All right. So a little bit of a follow-up from that, but really a little bit different. Sorry, I should stop qualifying the questions. I'm not doing a good job at that. Right now, health equity, social determinants of health, things like that are a pretty hot topic in the industry and something that everyone's looking to address. And telehealth is one way that some of those things can be addressed, even though it has its own issues. Do you see exceptions to policies being made for people who are disabled or might have transportation inequalities or issues or things like that, where telehealth has been a boom, but even as things might push back towards what the previous normal, you know, we'd be losing something in these areas that we're trying to focus on in equity and SDOH. Can you comment on that?
That's a great question. And I think we are seeing, for instance, enthusiasm for audio only telehealth. I didn't really talk about that, but that's something that is now reimbursed during the public health emergency. Lots of us fear, and we've certainly been giving signals by pretty much everyone that will ratchet back, but people have said there may be exceptions for shut-ins and folks that can't get out. So that's important. The other thing that we advocate for, which isn't really directly an answer to your question, but just want to put a plug in for it, is universal broadband. And so we're pushing very hard for that, because a lot of the social determinants inequities bit is about people not being able to afford broadband. So we want to push hard for that.
Yeah, I would just put in a plug that there's a wide gap between shut-in and easily able to get to something in person.
Mm-hmm.
And I think the medical profession in general tends to forget that. Not a comment on you specifically,
Yep.
but let's move on. So we have a question about the remote stroke protocols. Are those still in use? They were implemented, one of our attendees implemented this in Northern Berkshire years ago.
Say it again, please.
Remote stroke protocols?
Oh, yeah, no, the telestroke is doing well and I think growing. I mean, I know it was a pretty strong use case before the pandemic, and my colleague Lee Schwam at the MGH is a national leader in that regard, and set up a very big network around New England. So I'm sure that's still quite busy. So yes, as far as I know, it's doing well.
Great. So there's sort of a question and a comment together. Do you think that telehealth has the ability to fix the no-show problem that has plagued several providers, especially the F2HC market, where there isn't a potential financial penalty for not showing up? And the comment is that I'm sure that you'll have a more comprehensive view on this, but in a small study being conducted by this attendee, they're seeing that no-show rates drop precipitously in F2HCs with the introduction of video and telephone visits. So if you'd like to comment on that set of stuff.
Yeah, there's pretty good data that no-show rates go down. I think part of the reason is we as providers initiate those visits. So wherever we are in the the socialization of whether the doctor's time is important or not, or however you might want to view that, people seem to respect that when they get a call from the doctor, they pick up the phone. So I think that has to do with a lot of it. And we tend to run on time when we're doing telehealth, God bless us. And so that's another reason that it tends to be a win for everyone, is that, yes, I'll call you at 2:10, and by golly, I'll call you at 2:10. So you kind of wait by the phone, but not for long. And again, not in every case, there's been some, but generally I think those two things make it a win for that. And as I say, the no-show rates tend to be lower.
Okay, great. So now we have a couple of questions from the second session. Excuse me. How do you see the billing and payment process for remote monitoring working for patients? Do you see the devices being covered rather than just paid for by patients? Do you expect cost sharing for non-encounter based services? A lot of what you talked about were things that were happening behind the scenes rather than at an encounter that providers are doing. So how do you envision that part working?
Well, the current reimbursement codes allow for a clinician to prescribe, if you will, a remote monitoring device to get compensated for that device, to get compensated for teaching you how to use that device, and then for reviewing the data. So that's in place now. One of the challenges, of course, is that doctors don't necessarily want to carry inventory, so they develop relationships with companies that do the moving of the equipment for them, but they can get paid for that. So it's an ongoing developing area, because the other sort of other side of this is Fitbit and Apple Watch and things like that, which are of course not reimbursed. But there is, for mainstream remote monitoring of chronic illness, there's reimbursement codes now that allow the provider to give you equipment and get paid for it.
All right, well, it'll be interesting to see if that's the way that it starts happening moving forward. Thank you. So moving on to the AI portion of your comments. And this is my question. Is there any manual review after an automated triage session? I have a lot of experience with automated testing in the tech side, and automation only finds the things you specifically tell it to find. It will ignore 6 other problems that might be indicators of other problems, perhaps even serious problems. How do you handle that?
Well, I mean, that's kind of, I'm glad you asked, because I was trying to emphasize that people aren't to let their brain go to sleep. It's not, that's why it's such a your example is perfect for why it's such a foolish thing to worry about your job going away, right? It's especially a highly trained professional like yourself or a clinician. But I can't sort through looking at a patient in front of me and saying, oh, that looks like X. I can't sort through the 500,000 people around the globe that have already had that finding and predict where that's going to go. And so software can do that for me. I then have to look at it and say, you know what, I still don't believe it. I'm going to do X. That's called judgment. So it's just about realizing the kinds of things that we are good at and the kinds of things that computers are good at.
Well, I guess just a really quick follow-up. If the idea is that you only look at the people that what I took away from your original comments was that in this sort of mixed model, the human only looks at the things that were flagged by the AI, and the other pictures don't get examined. So if that's not the case, I apologize, but that's the impression that I got.
No, and that's good feedback for the way I present it. It is not the case, but I can see where you take that away. And so I'll next time I talk about this, I'll say it differently.
All right, great. We have one more question, and that is that healthcare was late to the virtual visit game, and you stress that provider organizations are still focused on bricks and mortar. Have you looked at lessons that we can take from other industries that have moved to digital business models but retain some bricks and mortar? One example might be banking.
Yeah, yes, it's a long-winded conversation, and banking, unfortunately for all of us, is the same. And the biggest reason is that currency is a uniform thing, and it's all based on that, whereas healthcare is unfortunately much more complex. But yeah, I think we can take lessons from companies like Uber and Lyft. Actually, I look at those as healthcare delivery of the future. Is how can we make it more like that kind of experience where your primary entry point is your digital device, and you get to meet a person at some point when you need one, but so much is handled for you before and after. I look at it that way, but it's a long journey and an important one at that. So I'll leave it at that, because I know we're running out of time. And
yep.
We got to close.
We are running out of time. This has been a great discussion, Joe. Thank you, Janice.
Yep.
We have some polling questions that we want to pop up on the screen for folks for just a few seconds. If you would take the time to answer these polls, we would be very appreciative. So the first one has just come on the screen as we speak. We'll let this run for about 30 seconds as the votes add up. We've just passed 50%. Excellent. Thank you all for your comments. Okay, we're going to stop that and that polling. And now we have sharing the results briefly that folks could see. And I believe we have a second polling question coming up.
Hey, Denny, nope, both were on there.
Okay,
1
Lynn.
and 2 were together.
Great. Joe, I want to thank you for your generous sharing of time with us today and your expertise in this exciting and fraught transformation, this disruption to healthcare. We at MHTC are excited about it. We see its benefits, we see its drawbacks, but we're especially appreciative to have experts such as yourself help draw the lines a little more clearly for us. And we thank you for that. I want to thank all of our attendees for joining us today. It's always a pleasure to pull together a crowd for such a good presentation, and we had a good audience today. So again, thank you, Joe Kvedar. And with that, everybody, ladies and gentlemen, we're going to adjourn. Thank you.